Perfect. Wonderful. Thank you so much for that lovely and kind introduction, Liz. I really appreciate the invitation to be here today. I am so honored and thrilled to be surrounded by a passionate group of advocates and activists as part of the Neonatal Justice Collaborative. My name is Shamita Punjabi. I'm a neonatal hospitalist at Stanford Medicine Children's Health, and I also spend part of my time working at pediatric hospitalist community affiliated sites at Stanford. And today I'm excited to share with you the work that we've been doing to develop a multi-site curriculum for inequities in newborn care that was informed by pediatric resident and community engagement. I wanted to acknowledge two sources of funding that we received for this project. The first is the Western APPD Pediatric Resident Research Grant that was given to our resident, Christina Konechny, for her work leading the focus groups that I'll talk about, and also the Picker Gold GME Challenge Grant, which was an 18-month grant designed to fund research supporting patient-centered interventions. I also wanted to thank my colleagues at Stanford who contributed to this project. Elizabeth Blacharzik, Shannon Chan, and Hannah Corman are also neonatal hospitalists in our group. And the four of us have worked together on implementing and studying the newborn health inequities curriculum here at Stanford. So I wanted to start off by setting the scene for a brave space. So a few years ago, I learned about the concept of brave spaces, which many of you may be familiar with when discussing health equity, racism, and bias. And now I like to start off all presentations and discussions on health equity by centering us within this brave space. So the concept of a brave space arose about 10 years ago out of an organization called Aware LA, which is Alliance of White Anti-Racists Everywhere, Los Angeles. And members of this group noticed that in dialogues investigating issues of race, there was a tendency for white people to claim that the space was not safe if they were challenged or became uncomfortable or felt that their opinions were not validated. So they moved away from the safe space and created the brave space, which reframes discomfort as a sign of growth and learning. And that to me is the core of being able to move towards productive and meaningful discussions around systemic racism and bias in healthcare. And operating within a brave space is especially helpful when we are using and teaching tools to combat implicit biases, and inequities in real time. So when we're feeling this discomfort of learning new information and reflecting on harmful dynamics, I encourage everyone to lean in and ask yourself, how might I be growing right now? And so today I wanted to keep that in mind and give you some background on why and how we went about creating a neonatal health inequities curriculum at Stanford and across our sister institutions in the Bay Area. I'll spotlight our resident focus group data and how this helps shape the content of our curriculum. And then I'd like to highlight one aspect of our curriculum, in particular, a health equity check-in that we're using in our neonatal setting. And finally, I'll highlight some future steps and tell you how you can get involved if you're interested. And then, of course, we'll end with some feedback and discussion from you all. So inspiration for this curriculum came about 3 years ago when we were asked a very seemingly simple question to give our trainees some resources on health inequities in newborn medicine. So initially we thought we might pull together some articles in the literature and a month or two roll out materials for residents. But we realized as we started to dive in more deeply that there were a lot of unanswered questions and not a lot of readily available resources, and we needed to take a more scholarly approach. So our team was concurrently seeing daily reminders of inequitable and judgmental care, many surrounding language barriers and implicit bias. So for example, we would attend deliveries and find that there was no in-person Spanish interpreters present with our Spanish-speaking families, and iPad interpreters were being used inconsistently. We felt that nursing and providers were quick to make judgments of families who were not at bedside. We noticed that our teams were not being consistently updating families who were not at bedside, and our families with a preferred language other than English were the ones that were most affected by this inequitable care. And as a team, we also had no organized means of acknowledging, reflecting on, or countering our implicit biases in the clinical setting. So these are just a few examples, and I think many of you can relate to some of these or even others at your own institution. And so I wanted to take a moment to allow you all to share some examples of inequitable care that you have witnessed, maybe similar to what I shared or other things that you're noticing. And just to help us think about how some of the themes or tools that I'll share today might help to address some of these inequities. So I'll give you all a moment if you want to scan the QR code or go to the Poll Everywhere website, and we can see some of your responses. And for those of you who aren't able to have access to scanning the QR code, feel free to share in the chat or unmute yourself as well. So I'm seeing challenges getting in-person interpreter services at night. Families that use profanity, sure. Yeah, absolutely. Inequitable use of security calls is something that we've discussed as well. Inconsistent use of MyChart for patients and families, of course, depending on the accessibility to being able to do that in many forms. Decisions made for families rather with families. Yep. Or for families with limited health literacy. Yeah. So kind of the lack of shared decision making that happens. Disparities in clinical outcomes, parking costs. Yeah, those are all really important inequities to note. Great. Thank you all so much for sharing some of these, I think, really important thoughts and really applicable to some of the things we'll be talking about. And responses to concerns families raise, inconsistent motivation to allow parents to hold infants, absolutely. Yeah, really important examples. I'm going to move on to some of our next slides, and we can definitely talk about some of these more during our discussion as well. Thanks for all participating. And so there was an op-ed in the New York Times on diversity training back in 2023 that really resonated with our team. And it was regarding the effectiveness of these diversity trainings to really change culture, and that the evidence is really not convincing at this point. This recommendation here from Robert Livingston is to focus on actions and behaviors rather than hearts and minds, which has been the major theme that has emerged for us as we've done this work. So the goal in designing our curriculum was to focus on our frontline providers and the actions that they can take on a daily basis to center equity in their care. And for us here at Stanford, I'm sure for many of you as well, our trainees are often these frontline providers, the residents and fellows, as well as some of our nursing colleagues and other allied healthcare professionals. So keeping all this in mind, we moved into the planning stages of our curriculum back in the fall of 2020. First, we identified the problem. As we continued to explore resources for our trainees, it became evident that no current data existed on resident knowledge, comfort with, or application of health inequities in clinical settings. And further, no current curriculum existed to support them in reflecting on and addressing inequities that was action-oriented. So to give you all some context on how we approached addressing the problem, I want to start with a bird's eye view of the project timeline, and I'll break it down a little bit more on the subsequent slides. We began our journey by speaking with multiple local experts, including neonatal clinicians and parent groups, residents, community partners. And to really understand the resident perspective, we conducted focus groups with residents over a span of 15 months over 4 Bay Area pediatric residencies, to learn about the gaps in training when it came to inequities in newborn care. We reviewed the literature on curriculum design and evaluation, and we concurrently assembled a 22-member professionally diverse group of individuals to inform the content and design of the curriculum before we piloted the first phase in May of 2022. So we identified 3 key partners in this work. The first is the parent perspective. We wondered if we needed to do parent focus groups, but found that this had already been done by Dr. Krista Sigurdsson in 2018 here at Stanford. So this is the qualitative study that was done, and it explored disparate care as identified by families in the NICU. 3 types of disparate care were identified, including neglectful care, judgmental care, and systemic barriers. So neglectful care was seen as less time and attention than was needed, less resources given, or a lack of timely responsiveness. Judgmental care included staff overtly or subtly evaluating a family's moral status, including staff using offensive language towards families. And systemic barriers to care were poor transportation, poor housing, employment demands, or other children at home. And most accounts, so about 96%, suggested that disparate treatment led to suboptimal care, and half of all accounts featured language barriers that cut across race and ethnicity dimensions here. Our next important collaborators are pediatric residents. We found the best way to hear their perspectives was through focus groups conducted by a resident champion. And finally, we engaged with community partners for their perspectives. We had 3 partners who met with us monthly as part of a larger curriculum group over a span of 18 months, and they informed both the qualitative research questions and the design of the curriculum. It has been vital to have the input of these community experts who are intimately familiar with challenges that our families face, both in the hospital and after discharge. So here is our curriculum design team. This work would not have been possible without our professionally diverse team. And we assembled this team knowing we wanted to best serve our patients and residents by gathering as much data as possible from multiple institutions who see a diverse range of patient populations in the Bay Area. So this group consists of faculty and residents from UCSF Children's Hospital, Oakland, and Mission Bay, San Francisco, Kaiser Oakland, and here at Stanford. And we also want to highlight our 3 incredible community partners from Glow Preemies and Sister Web, whose valuable time and contributions were recognized with the support of our grant funding. The resident and faculty leaders from 4 academic institutions completed focus groups and contributed content to the curriculum that's being adapted in various forms at each institution. I wanted to speak for a moment to our takeaways from engaging with our wonderful community partners in this project, because for our team, this was a really new concept, being able to work with them, and we were doing a lot of learning throughout this process and how to best serve them. Ashley Randolph is the founder of Glow Preemies and Preemie Parent Advocate. She's the mother of 3 children who were each born prematurely and were in the NICU, and she researches the implications of racial disparity for African American women and their premature infants, both pre and post NICU. And Marna Armstead and Deandra Hunden are respectively the executive director, co-founder, and director of workforce development at Sister Web, a network of culturally congruent doulas and birth workers for Black, Latinx, and Pacific Islander parents in the San Francisco area. So our aims were to understand their perceived gaps in provider knowledge and actions that we could take to meet the needs of their clients and patients via clinician education. So we met with them one-on-one before the 18 months timeframe, and again at the end, including an in-person meeting with them, including our team as well, to celebrate our accomplishments together. And at the culmination of our partnership, we obtained feedback, which was helpful in guiding our future partnerships with other community experts. So amongst their positive experiences, they noted being able to observe how the curriculum design happens and how teams collaborate across multiple sites to implement education. They appreciated sharing the experiences of patients and families, and primarily from the standpoint of empathy and understanding for barriers to care. And they enjoyed the sense of community and connectivity that we built over the span of 18 months through this group, which was really great to hear. The challenges that they shared included difficulty in grasping the hospital and medical terminology that was used during our meetings. The majority of our meeting participants were medical providers. They noted that regular check-in meetings on a more comprehensive education orientation would have helped them feel better equipped to participate in a meaningful way. So that was really useful to hear. And finally, they noted wanting support and education in understanding how resources that we were developing could be utilized by their own organizations. So overall, it was a really important lesson for us to keep in mind that community partnerships are really a two-way street. And while we did compensate and recognize the time and expertise of our partners, that we needed to continue to be actively cognizant of their dynamic needs in the work that we were doing. So next, I wanted to share the results of our resident focus groups conducted across our Bay Area programs. We had a total of 44 resident participants in the focus groups at 4 pediatric programs, 70% identified as female and 30% as male. And representing approximately a quarter of the total non-Hispanic white individuals make up the smallest segment at 23%, and the largest portion of the pie at nearly half was our Asian or Asian American individuals, making up about 45%. So each of our focus group transcripts was coded by 2 to 3 individuals, investigators based out of Stanford, using an iterative process that was based in grounded theory over a span of months to reach consensus regarding major themes. So we had 5 key themes that emerged from our focus groups across multiple institutions. Residents spotlight inequities in care, but they find it difficult to address them due to systems level barriers and limited action-oriented knowledge. They also express a high level of moral distress over the perceived inability to fully address inequities and seek a safe space to communicate these emotions. They desire protected time and systemic changes longitudinally throughout their training for reflection and action-oriented education. And they emphasize that faculty knowledge of, approach to, and role modeling of addressing inequities is key, and it underscores the need for ongoing faculty development. And finally, they note that collaboration with community partners, families, and multidisciplinary care team members is central to a well-rounded curriculum. So our residents really provided a very powerful voice to our curriculum, and I wanted to share an illustrative quote for each of these themes. So I'll give you a couple seconds on each slide to review them. For this first theme, one resident describes witnessing the variable care received by families with a non-English preferred language, with specific limitations on bonding, feeding, and kangaroo care, which were things that we identified earlier. So I'll give you a few seconds to review this quote. For the second theme, one resident describes the deep distress and fatigue that's associated with trying to fix the inequities that they witness, the notion that they're failing their patients and themselves. And reading this quote, you can sense that this speaker is really torn between helplessness and the duty to persevere for their patients. The third theme is underscored here by this quote, which emphasizes the thirst for action-oriented teaching. And this here is one of my favorite quotes that highlights our fourth theme, a resident giving an example of an ICU attending that they worked with who modeled addressing inequitable care. So this attending called out why a patient was receiving poor care. Specialty teams were not visiting a Spanish-speaking family regularly, and this was a form of racism. Addressing this inequity ended up changing the care that the patient received. And this excellent role modeling clearly left a lasting impact on the trainee. Finally, for our last theme is this great quote on the power of the multidisciplinary perspective, specifically how a lack of knowledge or familiarity with what our doulas and midwives do can manifest as mistrust and consequently affect our ability to trust and empower our families who really depend on these community resources for support. So I wanted to pause for some personal reflection here. I felt like I really related to these resident themes, and they normalized what many of us commonly experience, sort of this cumbersome and somewhat thankless nature of addressing bias and healthcare inequities in our day-to-day clinical care, QI, and research work, all a form of moral distress and burnout. That said, reading through these 4 focus group transcripts was really invigorating and reaffirming. And the call for action-oriented learning was overwhelming, and it really motivated us even more as we were putting this curriculum together. So with the results from our first focus groups, we began brainstorming our curriculum content in January of 2022. We really liked this conceptual framework proposed by Caress et al. To help inform the structure of our curriculum. And this framework shows the impact of various mentors throughout medical training that have on personal and professional identity formation. So a key piece of the framework is both the conscious reflection and unconscious acquisition of behaviors in the clinical setting, all learned behaviors that will ultimately impact professional identity formation. So keeping this in mind, we wanted our curriculum to offer a component of self-reflection that would complement the didactic learning that we may offer. In collaboration with our curriculum team, we devised these 5 learning objectives. So first is that residents will describe increased knowledge about neonatal health inequities. They'll identify health inequities in clinical care, demonstrate non-judgmental care when interacting with families with an emphasis on compassion and empathy. They'll have increased ability for reflective capacity around issues related to health inequities, and then they'll implement new learned patient care interventions to reduce health inequities in their clinical interactions. I wanted to highlight that Objective 3 was specifically pointed as important by our community partners, given the lived experiences of the patients and clients that they encountered. So our curriculum is called the Curriculum for Inequities in Newborn Care, or CINC. We piloted the first phase back in May 2022, and it included 5 active components. The first, at the 1 o'clock position, is a health equity library. Papers, videos, podcasts that we included to educate trainees on the history and landscape of health inequities in neonatal medicine. And this was made accessible to trainees electronically and on paper at their workstations. Next was a health equity toolkit that consisted of an action-based check-in used daily between providers to help center equitable communication in our care. And this is the check-in that I'll be talking about on some of the subsequent slides. Resident self-reflection was scheduled at the end of each 4-week block for residents to have a one-on-one check-in with faculty. And here they have an opportunity to debrief any challenging cases that was seen from the perspective of inequities and discuss any learning pearls from their colleagues in interpreter services and social work. Family communication was the QI aspect of our curriculum and was also a stipulation of our Picker Gold Challenge grant. Our metric aimed to always speak to a family in their preferred language using a certified medical interpreter whenever possible. And finally, faculty development was an important piece of the curriculum, which was supported by institutional training at Stanford and the creation of health equity rounds in our division of neonatology. So as we've collected data from attendings and residents, we've learned that the highest yield arms of this curriculum are the health equity rounds and the action-based health equity check-in. So the implementation of these 2 arms is currently ongoing at Stanford. Now I wanted to zoom into one aspect of the curriculum, which is an action-based health equity check-in. So this check-in was created to give our providers some guidance on how to organize conversations around inequities with our patient care. It was designed iteratively with feedback from our curriculum team and community partners, and based on the asks of residents within our focus groups. So it's a 2-sided document. The front side on the left is a stepwise review of the census to help reflect on implicit bias and center equitable communication in our clinical care. And then the backside on the right provides strategic strategies that the team can practice together to combat implicit biases. So we laminated copies of this and placed it in our workroom. And for our team, this check-in is best utilized before rounds, but other institutions and teams, which I'll talk about more, have adapted this tool in various ways depending on their workflow. I recognize that the font is very small on the slide, so feel free to scan the QR code and you can feel free to follow along on the next couple slides. So this is the front side of the health equity check-in. We implement this side of the tool on a daily basis whenever possible, and usually our residents and our faculty attendings participate prior to rounds. The tool becomes easier the longer that they're on service, especially for residents who know our families really well. So for step 1, communicate. This encourages us to think about how to communicate equitably with our families. So for families with a primary language other than English, we try to use an in-person interpreter over iPad interpretation whenever possible, and discuss timing for calling interpreters as well. We also talk about how to be mindful when we're communicating with families who may have experienced trauma or may have limited health literacy. In step 2, this reminds us to count that we've updated each of our families on a daily basis and ensure that we are documenting this in our medical record. Step 3, we pause to bring up challenges that the team or hospital might face when it comes to providing equitable care. For our team, the wait time for in-person interpreters is something that we will often discuss during this step. In step 4, we consider challenges the family might face during this hospitalization, often relating to social drivers. For example, if a family is not at bedside daily, could they have limited transportation or childcare? And then in step 5, we pause to consider how implicit bias within ourselves or the team might impact the care that we provide. This simple acknowledgement and awareness of the bias provides an opportunity for the team to discuss or share strategies that might help in combating the bias in real time with families and other providers, and it flows in really nicely with the reverse side of the sheet. On the bottom, we have action steps that gives the team an opportunity to either practice combating an implicit bias, sharing a health equity win that occurred during the week, or sharing a plan to go an extra mile for a family. The reverse side of the sheet gives examples for how the team can use a different strategy to combat implicit bias each day of the week. So an example is provided, but we really encourage teams to apply the strategies to their own patient census whenever possible. So I'll highlight one of these examples. We have a Spanish-speaking single mother with low health literacy who receives fewer medical updates with an interpreter because she's unable to be at bedside daily. So for example, on Monday, we'll work on perspective taking. So imagine what it might feel like to be assumed to be uninterested in the medical care of your child because you're not present at bedside or do not speak English, and we'll have a discussion about that. I realize that not all aspects of this check-in can be accomplished every day of the week. Sometimes a team may only have 1 to 2 minutes to focus on one patient or one step or one strategy. But with time and repetition, you can imagine that these discussions and tools become more embedded in the way that we think and practice and therefore care for our patients. As a result, equity becomes centered within the care rather than as an afterthought to the care. Next, we wanted to share some of our preliminary data regarding the impact of the check-in tool. And one of the advantages of this tool is that it can be adapted to areas outside of neonatal medicine. So we're actively studying this tool here at Stanford in our intermediate care nursery, and our colleagues at UCLA are also implementing this on their pediatric wards. And so I have data from both sites that I will share with you on these next slides. So we had users complete a survey both before and after using the tool. At Stanford, residents were the only study population at the moment, while UCLA, they also surveyed faculty, fellows, and medical students. A problem that both institutions struggled with was a low post-survey response rate, so the data is a percentage of respondents. The first question was, how often did you discuss health equity issues related to patient care? So after using this tool, both institutions found a much higher percentage of clinicians using the tool on a daily and majority of the week basis. We also asked respondents, in your last week of service, did you take a specific action to reduce neonatal health inequities? Stanford noted that those who responded, yes, I took a specific action, increased from 43 to 71%. Of note, UCLA only asked this question on their post-survey, but we thought it was really impactful that they noted 15 out of 19 people responded yes. Our surveys also had a free text option for respondents to share what kind of specific action they took to reduce health inequities. And so we chose 4 responses that most represented the common themes, those being that we included complex social issues in our handoff, we're being more intentional about calling families, discussing the impact of a family's cultural background on experience of care. And someone mentioned doing a lot of self-checks and reframing and perspective changing within the team. We asked, how has the health equity check-in impacted you? And some of the highlights from our providers were being more aware of racial and ethnic biases at work, helping with burnout and moral distress, and increased conversations with trainees about bias, which are not things that used to be talked about with regularity. Other providers commented that the check-in gave them a space to discuss struggles, which motivated them to keep doing the right thing, and also helped with active reflection on challenges that patients and our healthcare providers can face daily. So overall, we are excited that this tool has addressed several of the challenges that were brought up in our resident focus groups, and really look forward to iterating upon it with feedback from other people. We wanted to share what we think of as our wins and challenges. So the wins being the tool's adaptability, its ease to learn, And it's continuity, meaning that the team that follows patients longitudinally are more likely to be able to both recognize and address inequities when they're using this tool. Some of the challenges that both Stanford and UCLA have identified is difficulty implementing the tool on a daily basis, especially when the service is busy. And particularly at Stanford, we're finding that really challenging to do in our NICU. So we're currently on our second or third iteration of giving it a try. We've had difficulty including other members of the healthcare team, specifically nursing, as they are also frontline providers for a lot of our patients. And difficulty in finding a designated champion in each clinical environment, because that's really important in order for the tool to take hold. So as I conclude, I wanted to share what we're looking forward to ahead. We'll be submitting a focus group manuscript in the next couple of weeks, which is really exciting. We want to disseminate and iterate on this health equity check-in across additional institutions, which is one of the reasons that I am here today. And we really hope by gathering enough data and participants, altogether, we can work to submit a MedEd portal submission and share the utility of this tool more widely with other institutions. So with that said, if you're interested in getting involved, please send me an email. I currently have partnered with Stanford in the ICN, and then we are also working with the Stanford NICU. So the ICN is our intermediate care nursery. We're working on partnering with our pediatric wards. At UCLA, currently they're implementing it on their pediatric wards. Kaiser Oakland is using a near identical version of this check-in in their NICU, and they'll also be partnering with us soon to collect data. We are IRB approved at each institution and have standard pre and post surveys. So if you do decide to participate, more than happy to share all of our resources with you to make this a smooth process for you as you onboard onto the study. And then just as a reminder, this is adaptable to multiple clinical environments. So if you do work at other sites or have colleagues that work on other floors or other divisions, we are open to trying this in all kinds of different settings. And so definitely get in touch if you're interested. And so I'm excited to use the rest of our time together to hear your questions and thoughts and feedback. Thank you so much for having me here today. And I'm so honored to be a part of this community and work together with you moving forward.
Thank you so much. That was a terrific presentation. I'm going to go ahead and stop the recording. So we have our brave safe space for any questions that folks want to bring up or discuss.